popping up shortly. Okay. Can everybody see my screen okay? Yeah, okay. So hello, everybody. I want to thank you for joining our Interested Parties Engagement session today. This session focuses on therapeutic intervention services, which is under Section Policy 19, 20, 21, and 40. Next slide, please. So today, our focus is on activities and codes related to therapeutic interventions as defined on the slide, which again fall under policy section 19, 20, 21, and 40. So I'll quickly just kind of read that slide definition. So therapeutic interventions, also known as rehabilitation services, that are a healthcare service performed by physical therapists, physical therapy assistants, occupational therapists, occupational therapy assistants, speech language pathologists, speech language pathology assistants that are designed to support a member's ability to regain or improve function, mobility, or skills that have been lost or impaired due to being sick, hurt, or disabled. So we could just kind of read that just to make sure, you know, that's kind of the thought that we're thinking of when we're talking about some of the questions that we'll have later on. There are other services as well that may be looked at under this scope, and we'll talk about that a little bit more in the next couple of slides. So the next slide. So here, the current therapeutic intervention services we have identified with the assistance of Main Care. Those are actually displayed on this slide. There are 15 total for the section of policy 19, 20, 21, and 40. And I believe Emma has just put in the chat something, I don't know if it was the link or if it's the slides themselves. But you have those are all available to you out on the main rate reform website. There's actually two slides, and I'll just kind of briefly go through the codes here. So 92507, G0151, G0152, G0153, G9007, with all the different modifiers. And then on the next slide, again, additional G9007 with additional modifiers. The S8990 with the different modifiers, and then 0421 for the revenue code, 0431 and 0441. So when we're talking about some of the questions, these are the codes we're related to, and certainly information we want to hear from you about. We'll also display and show those when we get to those questions as well. So on the next slide, you know, just as our agenda kind of during the next 60 minutes or certainly less, depending on how it goes, we will quickly review the rate determination process, the project overview, goals and activities, and then get into questions and opportunities for discussion and feedback. So next slide. It's introductions. I will introduce the PCG team on the call. Myself, my name is Rhonda Kern-Stralzer. I'm a senior advisor of behavioral health and the lead for interested parties sessions on this project. Emma Feinstone is a project lead and a senior consultant. Maddie Wall is a business analyst with us as well. And then we also do have some of the Main Care team on the call, and I'll go ahead and turn it over to Kristen to start the introductions for them.
Thanks, Rhonda. Good morning, everyone. Thanks for joining. My name is Kristen Merrill. I am a senior policy manager for the Office of Main Care Services. I'm overseeing this project from the Main Care side. I am joined today by my policy colleagues, Tom Leet, who is the long-term services and supports manager, and Megan Brooks, who is a policy writer under the Main Care team. And it looks like Heather Binglis, who is also another policy writer under the Main Care team, is joining right now. With that, I'll pass it over to Dwayne.
Good morning. I am Dwayne Parsons, the manager of rate setting for the Office of Main Care. I am joined by our rate reform analyst, Jessica Levesque, our HCBS reform analyst, Jennifer Morris, and our rate setting coordinator, Amanda Lee. I'll pass it back over to Rhonda.
Thank you, Dwayne. So next, we're going to review the rate determination process, just a quick overview. So while this meeting focuses on feedback from participants regarding therapeutic interventions, I do want to highlight the process from a few slides on our kickoff call, which was back in August. The rate reform process does set schedules for regular rate reviews. Benchmarking creates a transparent process and includes technical advisory and comments, which are highlighted here on this slide. On the next slide, just again, kind of gives an overview of a little bit more about the process with the dates. So steps for the rate determination process include the kickoff call, which, as I said, it was held August, at the end of August, actually the 28th, and that can be found on the rate reform website. There's also public forums for feedback, official written comment period, and when that opens, we will let everybody know as well. Department review, and then final rate determination, which should occur around April of 2025. So that kind of gives you the timeline of where we're at. During this process, PCG will hold and conduct interested party sessions. We'll collect data, complete analysis, develop a rate model, draft rates, make presentations for comments, finalize rates, and then also make final recommendations for the rule proposal adoption. Also, I want to review a few items from an interested parties engagement standpoint. These meetings are the first kind of general meetings to start gathering information, and we anticipate future meetings with additional focus items, as well as the survey to gather more feedback. In addition, we do have an email set up that you're welcome to send information, comments, or questions to. And we will also put that in the chat, and then it'll be at the end of the presentation so you can see that as well. I also believe Emma has put the link for the rate reform website in the chat as well. So you can also go there as well. On the next slide. So again, following the established requirements for the rate reform process, this project focuses on home and community-based services, including assistive devices and services, care coordination, clinical services, clinical therapy services, supportive skill building, therapeutic interventions, which today's meeting specifically is focused on sections of policy 19, 20, 21, and 40. In personal support services, again, will be the entire focus of this project when you look at this as a whole. I do want to note that other projects are occurring simultaneously with other partners in main care during the same time frame, which are reviewing other sections, payments, rates, and codes. So if you are not seeing a section listed here, please check the rate reform website for other projects ongoing. Again, this section meeting will focus on the therapeutic interventions. However, if you're interested in providing feedback for any of the other services or sections listed, we have either had specific meetings for those, or we have a couple more upcoming, which we hope you do join and provide feedback. If you've missed some of the ones that have already occurred, you can go back to the rate reform website, look at the information there. And then you can also submit information to the, or if you have comments or want to provide any feedback on any of the previous sessions, you can send it to those emails or that email address, and we will, certainly document it and address it, or provide feedback, or those sort of things, whatever may be necessary. So the other thing I want to say is for any of the upcoming sessions, we do hope you would join. They are listed on the rate reform website, as well as in the kickoff presentation. And then emails do go out through the the main DHSS listserv, and we will also put those dates in the chat as well, and then also how to sign up for the listserv. So plenty of opportunities still for you to provide feedback if it is a service that your organization provides and you want to provide feedback and maybe miss that one, please reach out to us. We will love to have that information to add to what we already have. On the next slide, we're just going to quickly review our project goals. So really for us, we want to develop and document appropriate benchmarking, service definitions, rates, and coding alignment. We want to engage closely with interested parties throughout the whole project life cycle. So while this may be the first meetings, like I said, throughout the final project, which is April of 2025, we will have different opportunities, and you can engage with us as well at different times through that email. We also want to demonstrate the impact of changes to rates or service definitions, and then ensure alignment to state and federal reimbursement requirements. So on the next slide, just talks a little bit about the overview of some of the things that we've been doing. Currently, we've identified codes and rates for each section, and that list can be found on the rate system reform link, which I think is in the chat at this point. We have been analyzing codes, identifying benchmarks, and for services without benchmarks, we are going to be creating benchmarks with input from providers, certainly creating assumptions based on best practices and national trends. So throughout this project, engagement with interested parties will occur, and why additional sessions or information may be needed as we continue throughout this process. So again, look at, or if you're on the list serve, make sure you check out any of those sections or next opportunities as well to provide feedback. So with that being said, we're gonna go to some of the questions. I will quickly go back to the codes and show you, but first off, I will, review the question, and then I'll put those codes back up there. If you do want to respond, please feel free to put anything in the chat, or raise your hand as well and come off mute so you can talk. And then even if we go through the questions, we have to go back, that's okay. Not a problem at all, because sometimes we all don't think of something as, when it's right in front of us, it's like, oh, wait, this can happen later. So, or, oh, I just thought about that. That's fine. That's not a problem. We can do that. Also, even after the call, if you would like to reach out via that email and, ask a question or give information, please feel free to do so. That certainly has happened in some of our other sessions, even a couple weeks later or throughout the process. So please feel free to reach out in any way you feel. But we would love to hear some information or questions from you, as well as any of your feedback for our team as we continue this process. So the first question is, what concerns do you have about this rate determination process that you would like the team to be aware of regarding therapeutic interventions? I'll give people a couple.
Aware that the chat, you can't type in the chat.
Oh, let me make sure. It is on. See if you can chat, type anything in that chat now.
I can now, thank you.
Okay. Sometimes it doesn't like to play nice.
Gotta love Teams.
Don't we though? It's
Yeah.
great when it works.
Yeah. One of my concerns is that the rate for this service typically has never been comparable to what agencies are actually being charged by therapists for the consults. So it's like we're billing main care for it, but it's not even covering a portion of what we have to pay the actual providers. So I'm wondering how they're going to try and close that gap between what therapists are actually charging us as an agency to provide the service and what we're able to then bill main care for to be recouped for part of that. Does that make sense?
It does. So let's give a hypothetical. So like let's say for an example, um, the therapist charges $100 an hour, and main care, reimbursement is $50 an hour. Is the gap between, like that $50 gap in that example, i- is that what you're talking about?
It is. I mean,
Okay.
right now the rate's 17.29 per quarter hour. So the therapist charges us 150 an hour. So what we're trying to get reimbursed for barely touches it. And I understand that there's a portion of this that is a cost of doing business. I get that. But that's a very big gap between what the therapists are charging and what we can then be reimbursed for through main care.
Okay. Okay. That's a great example. Certainly appreciate you bringing that up, and also being the first person to speak up, because sometimes that's hard in a group. So first off, thank you for that. I think Emily has something in the chat. It says, Tammy, can you clarify so folks are aware you are specifically talking about consultation behavior in 21? And
Yes.
that was going to be my question. What code and what section?
Yeah, it is the G9007HI. I think I had mentioned this on the last meeting that I was at, but we weren't talking specifically about these ones. But it is for the behavioral consult under section 21.
Thanks for sharing that, Tammy. Can you clarify just for me, is this, is your agency commonly contracting with one entity, or is this something that you're seeing consistently across multiple agencies that contract with you? Um, and if so, is it, well, is it consistent? Is it always pretty much right around that same range where you're seeing that gap?
Yeah, so
Yeah.
with my current position where I am on the provider side, we contract with one person. But in my past experience, having been a main care provider relations specialist for several years and having providers contact me, this was a consistent message that they always outreached and said, hey, you're not even close to touching what it's costing us from a business standpoint to be able to provide these services to members and get them the help that they need. So consistently over the last several years, the rate has never substantiated what it's actually costing to get the members the help they need for this particular service.
Thank you.
Thank you.
And Tammy, can I ask a further question to that? And it sounds like you guys are contracting essentially with one person, but is that also a gap in sometimes the service delivery or quality of care for somebody because you cannot find someone that will provide that service?
I have heard that as well, that
Okay.
there aren't enough providers of the service that are willing to provide it or have the capability to be able to provide it to give the quality that the people need.
Okay. And that's what I was wondering, because if that was a challenge as well, with you discussing the reimbursement rates and that gap and the differences as well. Do you see it sometimes above that 150 for that consult then because of the decrease in the supply of providers that do that service? Is
I'm
that
sorry,
something that you've heard?
I'm going to make you repeat the first portion because your microphone kind of went in and out a little bit.
Oh, sorry about that.
That's
Um,
okay.
do you feel that people are charging more than that $150 because there's not enough of those providers, or the supply of those providers are less? I know you guys said that you have someone that you contract with for 150, but could it be more than 150 because people are charging more because they're like, we
Oh,
can?
I'm sure supply and demand is probably one of the pieces in play. And I can't speak for other providers. I know we've contracted with a few different ones over the years. And I can't speak for what other therapists are going to be charging, or because depending on their experience, of course they're going to charge more because they have a better knowledge base and they're able to maybe help a little bit more or think of some of those out of the box ideas. So they're probably going to charge more. But a lot of it is supply and demand. We all know that there's a shortage of therapists in multiple categories across the board.
Sure. Would anybody else on the call like to add to this discussion, or, provide any other feedback? Trina, go ahead.
I'm not able to hear Trina. I don't know if others can or if it's just me. Okay.
No, can't hear her. Can she type her question in the chat?
Now?
Yes.
Oh, we
Oh,
can
I
hear
can
you.
hear you. For some reason, my audio settings changed when I entered this meeting, so I apologize. I was just saying I wasn't sure how other agencies develop their rates for Northern Light Health, home care, and hospice. We've been doing our Medicare rates to be like 140% above what CMS would reimburse. So, and then with our commercial payers, we would have our rate determined based on what their guidelines if they process at CMS, and we typically will get our contracted rate, and we would generate our charges to be a certain percentage above that rate as well. So I'm not sure, like with main care, say if they have like Quimby, they're going to have a percentage. Medicare will process, we have our charge, and then we've got it generated to be 140% above the CMS payable rate. But then Quimby's only going to do their allowable rate. So how are we supposed to do our charge amounts when there's two different payers with different rate amounts? That could be something that makes it really difficult. So we're not charging enough and it's making main cares allowable because Medicare allows a certain amount and it processes, and then the Quimby after Medicare has a lower amount, so everything just has to be contractualized off. So that makes it difficult. And I
And
Trina,
just to clear,
Trina,
just to
Oh.
clarify from a billing standpoint, I understand what Trina is saying, because Medicare will pay, but then typically main care doesn't pay the full amount that Medicare does. So main care won't pay anything because Medicare has paid. Does that make
right.
sense?
Trina,
Exceeded.
can you clarify what services specifically is your agency delivering or contracting for?
We provide physical therapy, occupational therapy, speech therapy, skilled nursing, home health aid, social work. I'm trying to think if I've captured everything or not. But if main care's allowed amount is lesser than CMS's, then it would cause that contractual write-off because Medicare has exceeded main care's rate.
And that was going to be my question as well, Trina, as well as Tammy. So if, for an example, the service that's delivered, Medicare will pay $150, but main care only pays $80 for that. Is that what you're saying?
Since
Medicare, when they pay the 150, if
it's
if
the 80 that main care would have paid, so it's considered a contractual.
okay,
So it's
that's what
like
I
we would have to base our rates off of the secondary payer, essentially, if we wanted to get paid. But then Medicare would still pay, so we're kind of not in a win-win situation there. So either main care's payment rates need to be um, up, or it's just not beneficial, I guess, or it doesn't work with CMS. And I thought main care was typically around like CMS's rates.
okay. Okay.
Hope I didn't confuse anyone or speak out of turn here on that.
No, no, I think you bring up a very valid point, and what you're, not only with your organization you're seeing, or the challenges that you guys are facing between two different payers is number one, what I hear, right?
Right.
So you're you're looking, while somebody may have Medicare and someone may have main care, you guys are caught between those two payers and how to get paid for the services that that match what you guys are delivering. And sometimes it's difficult because of the gap between the two, is what I'm hearing.
Exactly.
Okay. Okay.
I'm
'Cause,
not sure if other agencies or facilities, member organizations experience that, but that's what I've seen on my end.
okay. Thank you for sharing that. Certainly is very helpful information for our team as we continue throughout this project. Um, thank you. Would anybody else like to add with Tammy or Trina and some of the maybe challenges, or maybe add to that, or maybe a different section of policy or different codes or something that they would like to maybe bring up? Well, I have on the screen right now the first slide of the codes. So, and I will share the next one again just to see if anybody, whoops, see if anybody, if that prompts something that, related to the question. If there is nothing else anybody would like to contribute at this time, like I said, we'll go to the next question if we need to come back, or if something else prompts you, please feel free to put it in the chat or raise your hand, and we can certainly go back. Let me go through my slides here and I'll go to the next question. So the next question, are there specific codes or rates for this rate determination process where you think changes need to occur for therapeutic interventions, and why? We did kind of briefly touch on that just a little bit ago, more in a general sense. But if there are specific codes that you guys would like to bring up, Tammy, Trina, or anybody else on the call, I know we've already brought up the G007 with the behavioral consult, but if there's other specific codes that are like that, like with physical therapy or speech therapy or occupational therapy, where you guys are seeing some of those gaps, or if you have other challenges you're facing, please let us know, and I'll put the codes back up on the screen again. And I'll flip to the next screen. Um, So if there's any specific codes that anybody would like to identify, or challenges, or related to the therapeutic intervention codes that you guys are seeing out there in the field and what you're working with every day, please feel free to put it in the chat or raise your hand, so we can learn more about this from you guys. So while you guys are thinking, I'm also in the other main care project, and I have heard from others, like with the um, physical therapy or occupational therapy, that sometimes there is difficulty recruiting those individuals, and that rate um, may not be where it needs to be. Some of those things. Are you guys seeing any of that in your current positions? Because I know, again, I see speech therapy, occupational therapy. As we know, COVID has impacted a lot of things. A lot of things have changed in the last couple of years. So is there anything that you're seeing with the other professionals? I know we mentioned behavioral health specifically, but are there anything with the other codes and those professionals that you guys are seeing as a challenge or gaps? Okay. Well, we will go on to the next question, and I will scroll to it. Like I said, if we need to come back, we certainly can. And I think we kind of touched on this a little bit, but are there gaps in existing payment methodologies for this rate determination process to highlight for the team regarding therapeutic interventions?
Just based on my experience in the past, there's a huge gap in what providers have to pay out in multiple services and what they can then charge to be reimbursed through main care. So billing what the private sector is charging providers is much different than what providers can then ask to be reimbursed from either Medicare or the state Medicaid programs.
And Tammy, that kind of goes back to also what I had just mentioned a little bit earlier about, a lot of things have changed, right? In the work environment, and no matter what field, or I think, or industry you're in, there's a lot of things that have changed. And so what I'm hearing you say is that the private sector, um, what you guys are paying for services, or being charged by certain providers to deliver that service, there's a gap in what you can get reimbursed for.
Right, and that's nothing new. I mean, I think everybody on this call is pretty aware that there's always been a gap. There's always been a difference, and unfortunately, in some situations, that's just the way it has to be. But I believe that in a lot of these services that are being provided, we can close that gap. So there still may be a small gap, but not as large of an expense to a provider as potentially it could be.
And to follow up on that, how does that impact the delivery of care for the patients or consumers? Do you see an impact with some of those gaps?
There potentially could be an impact, and it depends on the agency. I mean, if you have an agency that truly is looking out for the best possible care for the people that they're serving, it's going to be an impact that the member never sees, because the agency is just going to take that and cover it themselves, and they're not going to pass it on to clients or consumers. But then you have some agencies that honestly are just in it for the money, which is just a reality in the world that we live in today. But I know for the people that we support, we're just going to eat the cost. We're going to make sure that they get what they need, and we'll eat the cost and figure it out. But unfortunately, not every agency out there is willing to take that stance. And that's just reality, you know,
Accurate.
in any area of business or anything, you're going to see it no matter where you are.
Sure, totally understand. Trina, I think I heard you trying to come in, and then I see Rebecca has her hand up. So either one, please feel free.
Go ahead, Rebecca.
Thank you. Can you hear me okay?
We can.
Great. I just wanted to follow up on Tammy's comments. I think she's totally spot on that providers more often than not will absolutely shield the individuals supported from policy, payment impacts, whatever it takes to do the right thing. I'm Becca Emmons. I work for the Maine Association for Community Service Providers, MAXB. We're the membership association that represents service providers for children and adults with disabilities. I would just add one more piece to Tammy's thread, which is the size of the organization. So respectfully, Maine is a very rural state, and we have structured our network of providers that anyone can be a provider, big or small. So you could have an individual shop, you could have an organization of 2, 3, 400 professionals. And the ability for an organization to absorb that gap in payment can come down to just the respective scope and size of the organization. And when we have small rural communities and our network is relying on diversity of service provider mix, the gap between the market rate for clinical services and therapeutic intervention and the reimbursement, yes, there will always be a gap, but we need to recognize that our network being as diverse as it is and not just one big health entity means that we can't all as providers absorb that gap and continue to serve without adequate payment. Even if you are the most committed you've ever been to the individuals you're supporting, the reality of that over time is not sustainable. And so we're going to see larger organizations be able to sustain themselves, and smaller organizations, perhaps in more rural areas, continue to not be able to keep up with that payment gap.
I think that's very well stated. And certainly as you were talking, I can also, especially in those rural areas, that's sometimes where you start seeing the service is not available, right, to the people because they, like you said, they can't sustain. So, I think that was very well stated. And that is, you're absolutely right when we're talking about, when we start talking about payments and gaps and providers and what's happening out in the world, that certainly is something absolutely that happens. So thank you very much for bringing that up, because I think it does go very well with this. Um, Trina, do you want to
I was
add some more?
to say Tammy was spot on and Rebecca as well. I'm in a complete agreement with them. Most oftentimes, the patients should not be occurring an expense if agencies and facilities are following the policies and regulatory guidelines with their payers. Because, I mean, main care, if they're the secondary payer, they have their contracted rate, and you shouldn't be billing a patient unless they're applying it to the patient's responsibility, which doesn't occur if the primary payer exceeded the max allowed rate for that main care payer. So that should be contractualized and providers would eat that. So I don't feel like it's an expense to our patients because we're taking patients' care very meaningfully.
Absolutely. Thank you so much for identifying that and bringing that up as well. All three of you, thank you very much for contributing all those different pieces. And that's certainly one of the things that we, as our team goes through this project, we definitely need to hear those things as well, as we're looking at different pieces and aspects. So thank you. Anything else that anybody would like on the call to contribute or maybe add to that discussion? Tammy, do you want to, or is your hand still up? Sorry, from last time. Oh, okay. We will go to the next question, looking at time and trying to be cognizant of that. We just only have two more. I want to make sure we give time for those questions, but also to hear your feedback as well. So, but like I said, if we need to go back, we certainly can. It's not an issue. So the next question is, what do you think is most valuable for our team to know regarding therapeutic interventions for this rate determination process? And I can give you an example from one of the previous sessions that we had. The people on the call wanted us to know there's a clear difference between care coordination and case management. So that was an example that I can give you that the people that joined that particular call said, we think you guys need to really understand this. So I don't know if there's something like that, or, if there's something else in relationship to the providers or service delivery, or, some of those different pieces or geographical regions, anything like that. But is there anything that you feel is most valuable for our team to know as we continue to go through this rate determination process about therapeutic interventions? Rebecca, go ahead.
I guess I would just close by really championing the recognition of the market rate for therapeutic interventions. And so while we can appreciate that, supply and demand, and we have a very limited supply here in Maine of the level of professional that's required for these services, we still need to acknowledge that the market rate is what it is. So, and we have to be able to keep up and be competitive in order to meet the needs of the people who are looking for these services. And so I would just once again champion that, yes, part of the reason there's a gap is because there's so few professionals and we're all competing to secure them. But that doesn't mean that the market rate shouldn't be set aside when you are developing a rate for service reimbursement.
Thank you very much for adding that. And certainly something that we've heard, and we hear you, and we will absolutely take that into account as well. Tammy, go ahead.
I kind of want to piggyback on what Becca was saying too, as far as thinking of how large and spread out our state is. It's really hard to get services in some of those northern areas that people really need. And I think we just really need to keep that in mind when we're looking at all aspects of this.
Yeah, thank you for bringing that up. And as I said, I'm on another main project, and that is another thing that we have heard too from interested parties, is that, you know, there's clearly a difference between northern and southern Maine, right? And what's available, and service delivery as well as providers, those sort of things. So thank you very much for bringing that up. It just reinforces what already some of the things we've heard. So thank you. Other things that anybody else would like to contribute that our team needs to be aware of regarding therapeutic interventions and services? Okay. Well, like I said, if there is, we can come back to it. It's not a problem. We'll go to the next slide, which is the last question. Is there any additional information regarding therapeutic intervention delivery, payments, codes, anything of that nature that you would like to share with us that we've not talked about? And I can give you an example as well on this. In one of the previous sessions, you know, we were asked about, you know, the like rate model changes in HCBS at, you know, at the federal level, or, you know, looking at some of the payment or um, the changes going on in Maine, regarding salaries and wages, and, you know, some of those things. So it can be anything as broad as national, or it can be, you know, very state specific. It can be anything regarding therapeutic intervention services. That's something that we've not talked about at all, that you feel that we need to know, or maybe have a question about. We'll give a few more moments. See if anybody wants to bring anything up. Or again, if you want to bring anything up about any of the previous questions, certainly this is an opportunity to do that as well. Okay. Well, with that, we will start wrapping this up. So I will display the main HCBS project email. Anybody can communicate directly with us anytime during the entire project. Please feel free to reach out. We will respond to you, or affirm, or, you know, get you an answer, or you know, document your maybe your comment or your concern or something like that. So main HCBS C and N at pcgus.com. Please feel free to reach out at any time to that as well. As I said, we will have additional sessions that'll be more focused, as well as a survey. Our team is actually working on that currently, so it's about ready to go through all that's processes, and eventually you will get that information and get opportunity to maybe provide some additional information, or maybe very specific information regarding some of those codes, or other maybe challenges that you have for any of those future sessions. Like I said, please sign up for the listserv, check that out, sign up for any of them, or contribute if the survey comes out. We want to hear that feedback as we go through this. As like I said, that's part of the process here. So Tammy, thank you for your time, as well as the great discussion. Appreciate it. Same with Trina and Rebecca. Certainly appreciate all three of you speaking up, as well as providing different information, and certainly thank you. And that's exactly what these meetings are for, to give you an opportunity to provide any information. And like I said, there'll be some other ones too. So hopefully you do contribute. We'll look forward to that. And with that being said, are there any other questions or comments or concerns that anybody would like to bring up before we close out this meeting?
I just want to say thank you to everybody for participating. We appreciate your time and your comments, and look forward to working with you.
Thank you, Kristen. Thank you, everybody, for joining. Look forward to hearing or maybe seeing you at another future engagement session, and or in any other shape or form or fashion as well. So thank you. Have a great weekend. Bye.
Thank you. Have a great day.